Greetings. This is a lecture I gave on prosthetic gait deviations for a prosthetics course that Kessler threw in 2006, which would have been my first or second year as an attending. Not an easy topic to teach, but there's a lot of stuff crammed in here so that you don't have to go looking for it. I collected all of the information that we had from the various different prosthetic courses, our textbooks, and even stuff from our local prosthetists. So hopefully this helps. So outline, we're going to go basically through basic information about normal gait, levels of amputation, prosthetic componentry, and I do have an introductory prosthetic amputee lecture elsewhere that you can find. And then we'll move on to the gait deviations and we'll break it down into what's happening at the foot ankle and then, what happens at the transtibial and transfemoral levels. So this slide is basically my reminder of when I was in med school. I tried to understand Einthoven's triangle. That's what that thing on the left is. And this is basically how you can derive EKG potentials. And when I was in internal medicine, I just looked like a complete idiot because I could not read EKGs. When I got to ACLS, the instructor was a nurse and she told me to stop complicating things so much and just look for patterns. And so by looking at this pattern, I could immediately understand what was going on with the patient, whereas when I was trying to derive everything, not so great. And I think that applies here to prosthetic gait deviations as well. Although we are going to talk about how to derive everything, at some point you just see someone walking and you realize what the pattern is. This is a artistic rendition. Basically, this gentleman wore a suit with these lines, and then he took a photo of himself walking, and this is what it looked like. It's pretty cool. Got men dressed in black with reflective lines on their head, arms, leg, and feet, and had them walk or run against a black background while he took pictures, and the result was a linear graph of the motion. And I think the guy was a physiologist from France named Mary. So in order to learn prosthetic gait deviations, you have to understand normal gait. I can't go in super detail about this, but the slides do have all the information. First thing is you want to memorize the names and percentages of the phases in the gait cycle. So here we can see the gait cycle broken up into stance phase, or they're saying stance period and swing period. And then the stance phase is broken into tasks here: weight acceptance, single limb support, while the swing phase is pretty much just limb advancement. And then from here you get all the phases: initial contact, loading response, mid-stance, terminal stance, pre-swing, initial swing, mid-swing, and terminal swing. Yes, you have to memorize these. In terms of percentages of time, roughly getting a sense of when it's happening, and brief description of the actions that are occurring. So for example, with initial contact in a normal person, the heel contacts the ground. And, in loading response, that's when the foot is accepting the weight from the other side. I'm not going to go into all of these in detail. You should read these and learn these. Here is another table, which is pretty good actually, because it tells you at each joint, number one, where the ground reaction force is in relation to the joint. So the A here is anterior, so it's anterior to the hip, and what's happening during this phase. So for example here, hip extensors are firing for stability, and we are at 30 degrees of flexion. At the knee, the ground reaction force is anterior to the knee, hamstrings are countering, and the knee is fully extended. So again, powerful table here for you to use to memorize. So on this slide, we continue our discussion of normal gait with understanding the center of mass, energy conservation, ground reaction force. So basically the center of mass is the location where in a three-dimensional object where if you suspend from that spot, there will be no rotational forces or rotational moments. So in a human being, that location is right in front of the sacral promontory, which is about S2. So the ground reaction force is basically the force of the weight of the object on the ground being pushed back by the ground upward. This is a topic that usually I have to spend a long time discussing when people really want to get in depth. I've given you a definition here. Here we see that the ground reaction force location during quiet standing is pretty much through the hip, pretty much through the knee, and in front of the ankle joint. So if it's in front of the ankle joint, that's going to mean that it's going to cause the that means that it's going to cause the ankle to dorsiflex. There'll be a dorsiflexion moment on it. So during quiet standing, the one muscle that's firing during quiet standing is soleus. And what that does is it counteracts the ground reaction force during standing. Now, it is true that the ground reaction force is just slightly anterior to the knee, and so it is the posterior capsule of the knee that counteracts that, counterbalances that, and it's just slightly posterior to the hip, and so it's the anterior ligaments of the hip. I believe it's the Y ligament of Bigelow that counteracts the force of the ground reaction force at the hip. This is a table basically showing you where the ground reaction force is in relation to the hip, knee, and ankle during different parts of the stance, which was in your other slide. Here is some more explanation, and here we see another representation of where the ground reaction force is during the gait cycle. Here we see the 6 classic determinants of gait. This is a theoretical set of determinants that are believed to explain why we walk the way we walk instead of like G.I. Joe figures. So as you can see here, if you think of the hip and legs as just 2 sticks on, I guess hinges here, then, you're going to get this weird kind of walking, and the center of motion is going to be like this, and it's going to be all over the place. So if we add a knee joint in there, then all of a sudden it changes the way that the center of motion is moving. The more we add things like pelvic rotation, pelvic obliquity, lateral displacement, ankle movements, knee flexion, all of these things change it from what we call the compass effect to more like what we see with normal gait. And the whole purpose of all of these is to decrease the amount of motion that the center of motion displaces during gait, because the more motion there is, the more metabolic demand there is on the body to counter these. Levels of amputation are important to have memorized. I have a whole other lecture on this, but basically you can go from just a little part of the toe all the way to cutting off half of the body. These are levels that you should have memorized before moving on with the lecture. Some semantics that I discuss in the other lecture as well, that a prosthesis is the noun form and prosthetic is the adjective form. So you can have a prosthetic limb or you can have a prosthesis, and that is the correct way of using those words. And a prosthetist is someone who fabricates, designs, and delivers prosthetic limbs. Again, in my other lecture, I go into a little more detail about this, but there are different categories of prosthetic componentry. The first one is the socket. The socket is any part of the prosthesis which is an interface between the amputee and the prosthesis. Suspension is anything that actually contributes to how the prosthesis stays on the amputee. The skeleton can be either endoskeletal or exoskeletal. When it is exoskeletal, it's a shell, can't be modified, tends to be more durable, but also tends to be heavier. Endoskeletal tends to be lighter, adjustable, but maybe not as durable. And finally, you have different components contributing to knees, ankles, ankle foot, and these are components you kind of should know before you talk more about prosthetic gait deviations. So we're going to break down prosthetic gait deviations into those associated with transtibial amputees and those associated with transfemoral amputees. So let's start with transtibial amputees. So I guess I lied earlier, and we are going to go over all the different phases of the gait cycle as they are relevant to the below knee amputee. As you can see in this picture, this is a sound limb, and this is a prosthetic limb here, and you can see it from the side view as well as from the front, and we're going to have lots of these kinds of pictures later. So on initial contact, I guess the most important part for the BKA amputee is that the heel is striking with the knee in nearly full extension. There may be about 5 to 10 degrees of flexion there. The second phase is loading response. This is where the stance limb is accepting the weight from the now swinging other limb. So the ground reaction force initiates knee flexion only after full compression of the heel cushion that is in the foot. Until foot flat, the knee flexes quickly and smoothly through a range of approximately 25 degrees, or the same as the sound side. And the residual limb, which is the amputated limb, is down in the socket, and there should be no piston action. This is normal gait in a below knee amputee. During midstance, lateral bending of the trunk of 1 inch at the head occurs. The width of the gait base is up to 2 inches between the medial borders of the heels as the swinging foot passes stance foot. Foot flat occurs on the floor on the prosthetic limb, and the socket will displace laterally, but not more than ½ inch. Any deviation from this is considered a prosthetic gait deviation. At terminal stance, as the amputee passes over the prosthesis, the knee is extending until heel off, after which the knee motion reverses due to the passing of the center of gravity over the metatarsophalangeal joint. Knee flexion smoothly increases to equal that of the sound side. During pre-swing, which is when initial contact occurs on the other side. During pre-swing, the weight is shifting to the sound side without rise or drop of the head or torso, and knee flexion smoothly increases to equal that of the sound side. And then during swing, the prosthesis remains, the socket remains securely on the residual limb. There's no pistoning. The shank and the foot swing through the line of progression, and there's ample toe clearance. Any deviation from any of these factors would constitute a prosthetic gait deviation, and the idea is to be able to recognize those patterns. This is not something you're going to understand the first time you look at it, but as you watch more and more of these prosthetic gait deviations, it'll start to make sense. So now let's talk about what can go wrong in a transtibial amputee's gait patterns during initial contact. So we're calling this Malhotra's knee stability hack, but it's not really more than physiatric common sense once you've learned it. So when you hear the word stability at the knee, essentially what that means is knee extension. So when you're in your regular knee, when you have quadriceps firing, you get knee extension. Quadriceps gives you knee stability. A moment is a tendency toward a particular motion in physics. So an extension moment at the knee would be a tendency towards extension at any particular time. So I've put together all the things that contribute from a prosthetic standpoint to knee stability when we're talking about the foot and the prosthetic foot and ankle. So if there's more plantar flexion at the ankle, or it occurs too early, that will contribute to knee stability. If the foot is placed further anterior, it's kind of the same thing as having a long lever arm, right? Then that's going to promote stability at the knee. Also, if you don't have enough dorsiflexion, which is the opposite of plantar flexion, then you're going to have stability at the knee. And if your heel cushion is too squishy, then that also is going to cause stability at the knee, more of an extension moment. Instability would be a flexion moment at the knee. And so if you take each of these things that I have here and just make them the opposite, that'll cause instability at the knee. It really does simplify learning this stuff if you go with this slide. So if you followed that last slide, then this table should make it seem like I've just basically repeated everything. So at the foot ankle, if you have a dorsiflexed foot, that's going to cause instability or excessive knee flexion. If you have a stiff heel cushion, plantar flexion bumper, the plantar flexion bumper, if it's too stiff, will cause excess dorsiflexion, and that will cause knee flexion. And again, the foot location we talked about. So now let's talk about what can happen at the socket level. If the ground reaction force ends up more posterior to the socket, that will cause a flexion moment at the knee, which is excessive knee flexion or instability. If the socket is excessively flexed, again, that's kind of inherently excess flexion. If the amputee themselves has a knee flexion contracture, their starting position's already more flexed, instability at the knee. If they've got pain and they can't fire their extensors as a result of that, or they have weak knee extensors, then you have less stability, instability, more of a flexion moment. So that should kind of follow from the last slide. And on this slide, you can see if we put the foot further and further back on the socket, then we get kind of the same effect with knee instability. So this is probably the opposite, absent or insufficient knee flexion. So these would be all the opposite. Foot being anterior to the socket, excessive plantar flexion, soft plantar flexion bumper. This is everything that is extension moment. Opposite. So the next phase after loading response would be initial midstance, and if we go through all the different problems with midstance in the BK, to me, honestly, these seem very common sense. If the pylon is leaning too laterally, then it's the location of where the pylon is, or the socket has not been built in with enough adduction. And, basically the same kind of stuff for all of this. Lateral trunk bending, which would be kind of like a compensated Trendelenburg gait. Generally, I find that this is due to the amputee either having weak hip abductors or they've got pain and so they're not firing their hip abductors. If during mid-stance you do see a genu varum, which means that the foot looks like it's in more and the knee is coming out more, and there's gapping here in the lateral part and then it's digging in medially, it could just be, again, pain, or it could be an issue at the foot and ankle, or the socket. Again, I usually find that it's an amputee issue. As we progress through the gait cycle in the BK, we have terminal stance and initial swing. There's really, again, only two things that can occur here. You can have excess knee flexion or not enough flexion, too much extension, And all the same things in the Malhotra hack apply here again. In looking at someone from behind, you may see that the heel is suddenly moving medially or laterally. Again, it has to be from behind. And when this happens, it's called a whip. And it can be a medial whip or a lateral whip. And this is always a problem with the prosthesis and not something that you'll see with the amputee. During swing phase, all the issues that occur are due to inadequate toe clearance. And so what the amputee is doing to compensate for that. So if you do have an inadequate toe clearance during swing, you have to look for, is there not enough dorsiflexion built into the foot ankle? Is the pylon too long? Or is the suspension too loose where it's pistoning? The amputee also, knee flexion could be limited, or muscle weakness, or not gait trained, or having pain, etc. Vaulting is when the patient kind of plantar flexes on in stance phase on the other side so that they kind of jump up, and that helps them clear. Another thing they could do is circumduct, like someone who's just had a stroke. Asymmetrical step length and pistoning of the socket can occur to make it hard for someone to clear during swing phase. So that was everything for the transtibial. We can now move on to transfemoral. Again, we present the gait cycle, and this time it's with the transfemoral amputee. As you can see here, this is a transfemoral prosthesis going all the way up. And this is the sound limb here. So we have initial contact and loading response, then mid stance, then terminal stance, pre-swing, swing, and terminal swing. So this is heel strike. What's supposed to happen during heel strike is stability of the knee. So I've already given you the Malhotra hack for knee instability and knee extension and stability. And it applies the same here. It's just that this time, well, the foot and the ankle are the same, but this time the knee is prosthetic. So the knee joint may need some work if there's an issue there. Again, the socket is the same, and the amputee has the same issues. There's a link here that you can't click on. I will try and put the links in the YouTube video. If the foot rotates at heel strike with an associated vibratory motion, that could be that the heel or plantar flexion bumper is too stiff, or there's too much toe out. Foot slap is when there's excessive plantar flexion or it's too early, and so you hear a slapping of the foot. When this happens, there's inadequate plantar flexion resistance, or the bumper has been affected, or the heel is too soft as it's going down. If it's coming from the amputee, that means that they're driving the prosthesis into the ground at heel strike to ensure knee stability. So that's something that you can address in therapy. During mid-stance, there's basically just two things that you want to look for. One will be excessive lateral trunk bending. And issues can occur, again, at every level. The socket could be actually placed in abduction, and that causes them to need a wide-based gait. The foot could be set too far. The pylon could be too short. There could be inadequate support. And on the amputee side, it's probably more common that this is coming because of something like weak hip abductors or pain, especially medial groin pain. It's digging into their groin. And then some of them just have a habit of doing this. The second thing that can happen is just a short stance phase on the prosthetic side. And I think this is, again, generally either because the amputee needs training or there's just a poor fit of the socket on the amputee. Knee instability, of course, would also contribute to that. So now we're at terminal stance where there's heel rise. At terminal stance, it can feel to the amputee like they're stepping out of a hole prior to swing phase, and you'll see downward trunk movement during stance. So this could either be due to the inadequate dorsiflexion resistance or inadequate bumper of the dorsiflexion bumper, or the toe lever arm is too short, and the socket could be too far anterior with respect to the foot. So this is kind of another thing that can happen. Now we are going through swing phase. You can see an exaggerated trunk lordosis or trunk extension, and this could be all about anterior pelvic tilt with weak hip extensors, weak abdominal muscles, hip flexion contracture. These are all things that can be worked on in therapy. The socket could also have inadequate flexion built into it. During swing through and terminal swing, you may see a wide base or what's called an abducted gait. Other than stuff that could be going on at the prosthesis, I think the most important is that you got to look at the hip of the residual limb to make sure that you're not dealing with a hip abduction contracture. Circumduction, again, like we saw with the BK, similar stuff. Vaulting, we already talked about in the BK as well, so similar stuff. Excessive or early heel rise, we also talked about this in the situation where there was too much extension at the knee. Excessive terminal impact. So this is when initial contact is made, all of a sudden, smack, you hear the heel hitting with too much force. Usually this is the amputee trying to compensate for a feeling of that they can't get enough stability out of the knee. So just make sure that the knee itself is, the friction is, the mechanical friction or the hydraulic friction is dialed in properly. Swing phase heel whips, we talked about medial and lateral heel whips with the BK, it's very similar. Uneven arm swing, usually you'll see the arm on the prosthetic side is held close to the body, and although the most common thing is habit, this suggests that something doesn't feel right to the amputee and it needs investigating. Asymmetrical step length is usually, again, coming from the amputee and not an issue with the prosthesis. So just to round it out, I mean, you can use a gait lab to examine people's gait, or you can do what's called observational gait analysis. And as soon as you start recognizing these patterns, it's not going to be hard to see them. You do want to get a sense of what the difference between a gait deviation and normal is, and all the links that I'm hopefully going to be able to put in this YouTube video should help you to identify them. When doing observational gait analysis, also check them at quiet standing, look for alignment, check on the fitting, and usually my mentor, Dr. Eleanor Annan, kind of proved to me in her clinic that 95% of the time it was an issue of sock management. They weren't either putting adequate number of socks in or not watching how their shape was changing and needed more socks later, or maybe they were wearing too many. And then you can address a lot of this stuff in physical therapy by addressing flexibility, contracture, weakness, pain, and just fear by doing a lot of training. So these are the sources I used for this, and I hope it helped. Thank you very much for your attention.